Hi there, class. Welcome back. We are going to review Chapter 17, Coding Injury, Poisoning, and External Causes. In this chapter, we're shifting into injury-related coding, that is, trauma, burns, poisonings, and the external cause codes that tell the story of how an injury happened. As coders, our role is not to just capture what is wrong, but how it occurred and where it occurred and under what circumstances it occurred. By the end of this chapter, you should be able to recognize when external cause codes are needed and how to apply traumatic injury guidelines. We're going to practice using and assigning correct seventh characters for injuries and using the table of drugs and chemicals to find suggested codes. You're also going to learn how to distinguish adverse effects from poisonings, correct coding of burns, and identify abuse, neglect coding requirements. Finally, we'll look at complications of care and what documentation is required before we can legitimately call something a complication. Here are some key terms for this chapter. Injury types like avulsion, laceration, fractures, and concepts such as malunion, non-union, and rule of nines are some of but a few of the terms that we are going to refer to. And I'm going to refer back to these terms as we move through some of the examples. So make sure that you're comfortable with them because they are going to show up frequently in real-world documentation. Section 17.1 focuses on external cause codes. These are the codes that explain how an injury occurred. Think of the external cause codes as the narrative part of the story. That is, they're added after we've coded the actual injury itself. External cause codes can tell us four main things: the cause, the place, the activity, the patient's status at the time of the event. And these details are valuable for injury research, prevention programs, and sometimes payer reporting. Another thing that we see with the external cause codes is we see, like, for example, research and development over safety of the use of seatbelts. If you're a driver, if you're a passenger, you're using a seatbelt, and how it correlates to the type of injury. Was it an injury, a motor vehicle accident that occurred on the street versus, losing control and hitting an object? How fast was the vehicle going? Things like that are going to determine or help determine prevention and new safety initiatives for prevention research as we move forward. External cause codes are never first listed codes. They are never listed as a first diagnosis or as a principal diagnosis. They always follow the injury or the condition coded. You'll only report them as secondary codes and never by themselves. They must be connected to a particular injury or an event. Cause of injury codes identify what actually caused the harm: falling from a scaffolding, being stepped on by an animal, or forced landing of a balloon. We also use these codes for intentional harm, such as domestic violence, child abuse, elder abuse, which is often found in the Y07 category. Place codes in Y92 tell us where the person was when they were injured. Were they at home, in a nursing facility, at a pool, etc.? The same injury, like slipping at a swimming pool, could have a different place codes depending on whether it's a private home, a group home, or institutional facility. So we see all sorts of place of occurrence codes. And it's important to identify through the gleaning of the documentation where this injury occurred. Activity codes in Y93 explain what the patient was doing, such as dancing, gymnastics, Maybe they were horseback riding or cheerleading or yoga, anything, any number of things that they could have been doing, which, when the accident occurred. These codes are especially useful for sports injuries and help public health experts track which activities carry a higher risk. Status codes in Y99 complete the picture by showing if the person was at work, in military, whether they were volunteering or engaging in leisure or student activity. This helps differentiate, for example, a workplace injury from a hobby-related injury, which could have legal and insurance implications. Next, we have 17.2 traumatic injuries, which we'll review many named fracture types so you can connect the clinical phrase to the documentation to the correct code. This group includes avulsions, burst, comminuted, depressed, fatigued, fissured, fractured. Now notice how each term describes the pattern of the break, whether the bone is in pieces, whether it's crushed, pulled off a tubercle, or cracked along its length. So there are different types of traumatic fractures, and it's really important to select the appropriate code for the fracture type. And sometimes providers aren't, they may not document that granularity, but it's important to look through the medical record, look through that encounter to determine, the type of traumatic fracture. And sometimes that's identified in a radiology report. It may be identified in an X-ray or an MRI, in which you can take that information and go from there. On this slide, we see green stick fracture, impacted, infected, and specific patterns like lateral mass fractures of C1, as well as Mason-Naves fracture of the fibula. A green stick fracture is a common fracture that occurs in children due to more flexible bones. Mason-Naves is a spiral fracture linked to an ankle injury mechanism. Oblique, parosteal, pylon, puncture, and segmental fractures all describe unique orientations or mechanisms. For coders, recognizing these words in the report helps you choose the correct code category and the laterality. Salter-Harris fracture is a very common fracture, and it involves the growth plate, which is key in pediatric patients. A spiral, torus, transverse, transcondylar, and wedge compression fracture each have characteristic radiographic appearances that often drive the terminology in the note. Documentation may not literally say open or closed. Instead, it might use terms like compound, missile, puncture, or foreign body for open fractures. Closed fractures may be described as comminuted, depressed, green stick, impacted, or spiral. Pay close attention to these clues when you're assigning the code. If it is not mentioned that the fracture is open or closed, it is okay for a coder to assume that the fracture is closed. Skull fractures are described differently. You may see a basal skull, blowout, depressed skull, stellate fractures. They all have distinct locations and patterns. Accurately capturing the skull fracture type can influence both the code and the expected clinical severity. The fort fracture are classic facial trauma patterns and come in three main types, each with different involvement of the maxilla, the nasal bridge, and orbital areas. Codes like S02.411 to S02.413 reflect these patterns. So when you see the fort 1, 2, or 3 in the report, you should immediately think of these specific code ranges. Sometimes fractures don't heal correctly. Malunion means the bone healed in the wrong alignment, while non-union means it never fully healed together. These late effects are sequelae, and they impact both the seventh character and the selection of codes when the patient is seen for ongoing problems. Traumatic wounds include lacerations, contusions, hematomas, puncture wounds, avulsions, and animal or human bites. Accurate documentation of depth, site, and any foreign body is absolutely essential for picking the correct injury code. Here we distinguish between strains, which are the muscle fibers, sprains, which are the ligaments, contusions, which are bruises, tears, and ruptures. The term myalgia simply means muscle pain, which might be coded differently from a documented tear or rupture, so pay close attention to any wording. Section 17.3 introduces seventh characters, which show the phase of treatment or healing for fractures and some other injuries too. These seventh characters are not optional. If the code requires 7 characters, you must use one code, and you must have a valid code. So the 7th characters for fracture care are as follows. The A and B are for initial encounters. D, G, K, and P are for subsequent encounters, which reflect routine healing, delayed healing, or non-union, or a malunion. And S is used for the sequela. Section 17.4 focuses on the table of drugs and chemicals, and this is your main tool for coding poisonings, adverse effects, as well as toxic reactions. This table usually appears right after the main alphabetic index in your ICD-10 codebook. In this table, you'll first look up the substance, sometimes by brand name, sometimes by generic name, so it's important to know both. Vesicare, for example, is a brand name. Solifenacin sulcinate is a generic, and its category might be documented as a mucineric receptor antagonist or anticholinergic. Section 17.5 deals with different ways a substance can cause harm, adverse effects, poisoning, underdosing, and toxic effects. Now, your job as a coder is to review all of the documentation and review those coding guidelines to decide which scenario applies before coding. An adverse effect occurs when the right drug is given to the right patient in the right dose via the right route. However, the patient has a negative reaction. In these cases, we code the reaction first and then an additional code to show the drug responsible as an adverse reaction. Poisoning, on the other hand, involves an incorrect or harmful exposure. Maybe too much of a drug was taken, or the wrong drug, or an exposure was intentional or accidental. You'll need to determine from the documentation whether it was accidental, intentional self-harm, assault, or another specified circumstance. Underdosing occurs when the patient is not taking enough of the medication. This can be intentional or non-intentional. Codes in the category are codes in Z91.12 to Z91.14 range allow us to show reasons such as financial hardship, age-related issues, or other non-compliance with the medication regime. Toxic effects are reactions to non-medicinal substances, things like industrial chemicals, environmental toxins, or other harmful agents. These are captured in T51 to T65 code range and are separate from medicinal poisonings and adverse drug reactions. Interactions can occur between drugs or between drugs and alcohol, food, or even a specific beverage like milk. You might see instructions such as "do not take with dairy" warning about an interaction that can change absorption or even impact the drug. Now we're moving into burns, and Section 17.6 covers burns and corrosions. These require multiple codes to describe the site, the severity, the extent, as well as the external cause. Now we're going to use a helpful mnemonic here, S/S-EE, to remember the sequence of burn codes. So the first listed code, S/S, is the site and severity, which which is in categories T20 to T25. Next listed we have E is the extent from code category T31. Last listed is E, external cause codes, so SSEE. Important to be able to differentiate T code categories as they specify which body region is impacted, whether it's the head and neck, the trunk, the upper limbs, hands, lower limbs, feet, eyes, respiratory tract, etc. Make sure the physician documentation clearly states the site. So example, right lower leg versus foot. So you can, choose the correct category. First degree burns affect only the epidermis and appear as redness or erythema. Second degree burns involve blisters. Third degree burns extend through the dermis and fat, and deep third degree burns may show tissue necrosis and possible muscle involvement. Within a region, codes can get very specific. For example, distinguishing burns of a thumb versus a single finger, multiple fingers, the palm, the back of the hand, or wrist. These details come through documentation and help you narrow to the correct fifth and sixth characters. Here we have an example of a patient who burned the back of his right calf on a motorcycle tailpipe. And we're going to walk step by step from T24 to T24.32 or 231A. As we do, notice how each additional character adds more detail, whether it's a degree of the burn, the exact site, etc. So for this example, Troy was talking to his buddy. He stepped back. He hit the back of his right calf on the tailpipe. So the first three characters are that T24, burn and corrosion of lower limb except ankle and foot. The fourth character, so we're taking it out, burn of second degree of lower limb except ankle and foot. So that's the T24.2 because we have a second degree burn. Then the fifth character takes us to second degree of lower leg. The sixth character takes us to the laterality, which is the second degree of right lower leg. And then the seventh character, which is last but not least, tells us the whole story, the burn of a second degree lower leg, right lower leg initial encounter. The next code you'll have to report indicates the extent or the percentage of the body involved. So T31 is for burns and T32 is for corrosions. The description will specify the percentage of body surface and, if applicable, percentage that it is the third degree. So a rule of nines. Rule of nines is a quick way to estimate the likelihood of basically the burn, where the burns have been on the body and what is the appropriate percentage of burn on the body. So we look at head and neck as 9%, each arm is 9%, the trunk is 36%, genitalia 1%, and each leg is 18%. Clinicians often use this estimate in the note, and as coders, we use that documentation to support the appropriate T31 or T32 code. Burns can become infected because deeper tissues are exposed and they're harder to keep sterile. If the documentation confirms an infection, add a code for the specific pathogen sequencing after the burn code, but before the extent code. So if the pathogen is known, make sure that you capture that. Some burns have their own codes, which we see the L55.0 for first degree, L55.1 for second, and L55.2 for third. And even though these are everyday conditions, they are still coded with the same attention to degree and severity of other burns. Other skin reactions to sunlight, such as drug-related phototoxic or allergic responses, are coded in L56. These conditions include photocontact dermatitis and solar urticaria, which may be triggered when the UV light interacts with drugs or chemicals or in the body. Next, we're going to go on to section 17.7, which covers the sensitive area of abuse, neglect, and maltreatment. The documentation and coding must be handled very, very carefully. The codes distinguish between confirmed abuse and suspected based on what the provider documents. T74 is used when abuse or neglect is confirmed by the provider. T76 is used when it is suspected but not yet confirmed. A coder must not make assumptions. This is what we've talked about throughout this class, is you never want to assume. You never want to assume that, if a patient is taking opioids for an injury, we don't want to assume that there's opioid abuse, or if they drink alcohol, we do not want to assume that there is an alcohol dependence or alcohol abuse. We need to tread very, very lightly and very carefully with this. Same goes with HIV infection versus AIDS. So, just want to put up that red flag that you must tread very, very carefully with these conditions. For a pregnant patient, codes in the 09A.3 to 09A.5 range show physical, sexual, or psychological abuse complicating pregnancy, childbirth, or the puerperium. These codes highlight that the abuse is affecting not just the mother, but also the outcome of the pregnancy. Z04.4 and Z04.7 capture encounters for examination and observation after alleged rape or alleged physical abuse. These are used when the purpose of the visit is assessment and observation rather than treatment for a specific injury. In our last section, we're going to look at complications of care, conditions that arise as a result of medical treatment. Not every bad outcome is a complication. There must be a clear cause and effect relationship documented. So before assigning a complication code, you need to explicit or think about documentation linking the device, procedure, or treatment to the problem. For example, pain from a cardiac prosthetic device. You have to have that linkage in the documentation. Otherwise, again, it's not, if it wasn't documented, it wasn't done, and it's not a problem. So in this example that we see, we pair a specific T82.847A code with the appropriate G89 code to indicate acute or chronic post-procedural pain. Injury or poisoning codes require you to think beyond a single code and really think outside of the box, because you're telling a complete story of what happened, of how, where, and under what circumstances this patient was in. Whether you're dealing with fractures, burns, adverse effects from drugs, abuse, accurate coding supports patient safety, quality reporting, and appropriate reimbursement. With that, we are at the end of our chapter. Thank you. We'll see you next week. Bye-bye.